May I invite all the speakers, please, to come to the podium? Roberto? Yes, Ibrahim, please. Walid and Dr. Ratel. Okay, so I'd like now to open the floor for the questions. Ibrahim, let me just start by you. Now, the guideline clearly indicating the importance of having a single pill combination. All the clinical pharmacists in different hospitals are very resistant to this concept. Yeah, single pill combination for hypertension management.
My hospital is also resistant to this.
Why is this, although the guideline is very clear?
I can tell you. We only have perhaps a couple of combinations. Hyazar, if you allow me, and Hyazar and the other, and Fortzar. This is the only combination we have. The problem is really inventory and the cost. Remember, hospitals... Can you hear? Near? I'll keep it near. Yeah, thank you. This one requires to be very close to the mouth. Okay. So really, majority of hospitals, they really wonder about first maintaining the inventory and the cost of the inventory. But really, a lot of time, in the hospital, you have supervision from nursing staff and physician. In the community, you don't have this. So I have a patient admitted in the hospital. Now remember, many hospitals in the UK, not only in the UK, many hospitals in Canada and US, you only treat patients while they are hospitalized. Then you write them a prescription to buy from the drugstore. Over here, the situation is slightly different. You see them, particularly in a big hospital and governmental hospital, you see them as inpatient, you also see them in the outpatient, and you give them inpatient medication, outpatient medication. In the West, this is not the case. You prescribe, you give them medication, they buy it themselves, or they have insurance coverage, then the insurance will pay. So hospitals here tend to spend much more on medications, and really add the single pill is really adding inventory and adding cost and increasing the drug budget. Well, your drug budget will mainly be going to the difficult to treat conditions, equipment, and so on. Dr. Walid Basata wants to have state-of-the-art technology for his cardiac, whatever, imaging. I want the oncology department wants to have state-of-the-art medications. Transplant patients are very demanding, and so on. So you cannot really afford to buy most of these single pill combinations. Particularly, you have somebody being treated under supervision in the hospital. This is really most of the time how people really look at it.
Thank you. I think the issue is really more than that, but I think the time doesn't allow us for this. Now, Roberto, the question to you, I mean, you show us a very good evidence about the difference between AC and R, but all the guidelines does not showing that difference. As a matter of fact, we always, in open any guidelines, always AC is the second phase for R.
This is a very important question. I'm afraid is a very political question, and I have to be careful in what I'm saying. The guidelines, if you read them properly and carefully, if you read the text, they clearly say that ACE inhibitors are more cardioprotective and there are more data than the ARB. However, we are reading the guidelines very quickly, always looking at few sentences, and the sentences says ACE inhibitors or ARB if ACE inhibitors are not tolerated. And it is in this if they are not tolerated that there is a lot of confusion, because particularly for hypertension, all suddenly the ACE inhibitor produce 20 or 40% of CAF, which they do not produce the same CAF in patients with heart failure, for instance. So when I'm said it's a very political and I have to be careful is because even the guidelines, how to say, there are lobbies, and you try to understand me, and so there are pushing. Now that the ARBs are all become generics, you will see that CAF is less of a problem with the ACE inhibitor, and will be less lobbying. But that was the situation, at least in Europe. Because you shouldn't forget that the ARB were somehow created in order to overcome the ACE inhibitors because they were becoming generics. And they have been done with a good purpose, and of course, and in the hope that they could really represent an advantage. But in this particular field of cardioprotection, unfortunately, this advantage is not there. And it has been shown by many meta-analyses. And, but, you know, people sometimes are under the influence of marketing and so on. And that is what is happening. That is my personal opinion, at least.
Yeah. I have, if you allow me, one question to Professor Peterson. Always when we hear about guidelines, we hear about target or goal in the guidelines. And it's very confusing to me. I'm working in hypertension, and this is very confusing to me. Hypertension and coronary artery hypertension and heart failure, hypertension and stroke and renal and diabetes and whatever. The goal is different even from one age to another age. What is your comment? Our problem is to control the blood pressure as much as we can. But how we can remember always, most of the time, the goal and the target for blood pressure goal from different patients, and sometimes we have one patient who has 3 problems at the same time. So tell me how we can manage for the goal. Thank you. Difficult question, I know.
It's a very difficult question because, in my opinion, in my opinion, acceptable range tension blood pressure range is acceptable range 120 to 140 acceptable range, better than one target number. If they have hypertension but coronary artery disease and diabetic patient, very low systolic blood pressure and very low diastolic blood pressure increase the mortality.
Next to your mouth,
Therefore,
microphone.
The target range.
Yes, thank you.
We have to focus the target systolic and diastolic blood pressure acceptable range 120 to 440 systolic and diastolic only 80 millimeter mercury strict range. Over the very low hypertension may be dangerous for increasing mortality, increased hospitalization, heart failure. Therefore, acceptable range is better than one target number, in my opinion.
Okay, thank you very much. I think we have a lot of questions, but because of the time, we have to conclude the session. Thank you very much, and inshallah, see you in the next session. Assalamu alaikum.